Three, two, one. We are live now, sir.
Good evening, doctors. I welcome you to the next edition of Cannabidiol, Epilepsy and Beyond, Newer Vistas in Neuropsychiatric Disorders, with a special focus on the psychiatric domain. To do the honors of today's program, I invite Dr. Dhananjay Asturkar, the moderator and chairperson of today's program.
Good evening, sir.
Yeah. Dr. Dhananjay is a consultant psychiatrist, director of Asta Psychiatric Nursing Home at Chinchwad, Pune. He has done his DPM from GS Medical College and KEM Hospital in Mumbai. He has a vast teaching experience of 5 years as assistant lecturer in DY Patil Medical College. He has been the past secretary of the Indian Psychiatric Society Maharashtra State Branch, Pune Psychiatry Association, vice president of Pune Psychiatry Association, as well as the honorable zonal secretary, Indian Psychiatric Society West Zonal Branch in the year 20 to 24. Besides, he is also executive member of SMART. I call upon you, Dhananjay sir, to take this program forward by inviting the speaker, Dr. Prashant Chaudhary.
Good evening, sir. Thank you for this wonderful introduction. First of all, welcome Prashant.
Thank you, sir. Thank you so much.
Welcome Akhil also. Nice to see you after a long time, Prashant.
Thank you,
How
sir.
are you?
Likewise. I'm good. How are you doing, sir?
Yes. But I think today's topic is something different. I am very much eager to hear from you because it's something different composition we are having. And definitely it's used by the pediatric neurologist recently in a very huge responses there. But
Yes,
little we don't know about exactly about how it is going to be for the psychiatric disorders. So
yes.
what could be the what possibilities of getting the official recognition as a indication for this drug, and also where we can always we are interested in using drugs off level indications,
Yes.
during our clinical practice.
Yes, sir. Yes.
So with this note, I welcome you, Prashant Sunil Chaudhary, and you have beautiful and very short introduction of yourself. बस प्रशांत चौधरी नाम में सब कुछ है. Prashant has done his DPM from Sion Hospital, one of the reputed hospital in the Mumbai, and also he is consultant psychiatrist at Bandra Care Clinic. I welcome you, Prashant, and hand over the mic to you. All
Thank
the
you.
best.
Thank you. So, can I present from my end, right?
Yeah. Please, sir.
Is it visible now?
Yes, sir.
Yes, sir, we can see your screen.
I'm just trying to change the slides. Just a second, huh? Is it like, can we see the change slide as well?
No, sir.
Wait, is it visible now?
Yeah, the slide is visible, but we cannot see the transition. Yes, sir. The
Okay.
slide change. Yeah. So I think slideshow. I think you have not put on the slideshow. Maybe.
Just a second. I'm just putting on the slideshow. Is it
Yes, sir.
visible now?
Yeah. Perfect, sir. Perfect.
Yes. So again, thank you so much for that warm introduction, Dhananjay sir. And I believe I'm just starting out. So all Dhananjay sir and even Akhil sir, they are senior to me. I'm just here to share my clinical experience with use of cannabidiol in my practice that I have over here. And I would like to share that with all of you. I would rather like to bounce it off of you to understand more about the use of cannabidiol and where I'm going with it. And if experiences from all of you can help us, use it in a better way, since it is one of the new things which is available to us now. Apart from, and as always, when it happens, in psychiatry, we have the dearth of the things to be using. And there are so many complex conditions for which sometimes we find ourselves at a loss, what should we use now? And hence, this is what I'll be presenting today. So I'm changing the slides. Just let me know if at all there is any, problems while if I'm changing the slides, if they are not visible. So it's visible now, right?
Yes, sir, it's visible.
Okay,
Yes,
okay.
sir.
So just the first slide, it's a very simple, like I won't be spending too much time on the theory of it. Just a few slides to indicate why I have been using this particular molecule in many of the off-label indications, as I have been the theoretical basis of it. We all know that what is the role of the cannabinoid endocannabinoid system neurotransmission in our body. Again, these are all proposed hypotheses. We know that brain is not as simple as a lock and key that is shown in this figure. There is a presynaptic neuron, and from presynaptic neuron, a neurotransmitter is released, which attaches itself to the receptors on the postsynaptic neuron, and the neurotransmission happens. This is the simplest thing most all of us know about it. Then from postsynaptic neuronal membrane, these endocannabinoid molecules are released, which act on the receptors on the presynaptic membrane, and it in that retrograde fashion controls the release of the neurotransmitters in most of the neurotransmissions in our body. So very simply, this retrograde neurotransmission is the key where this endocannabinoid signaling system works in our brain, to most extent. Okay. Now, taking it to the next slide, we know that there is a CB1 and a CB2 receptor. The CB1 receptors is mostly, concentrated in the central nervous system, and the CB2 receptors is mostly present peripherally. With basically these cannabinoid receptors are there in entirety of our body. Now, there's this next article. Now, before I get into this article, I just want to take you to there is this one research on late adolescent onset of prefrontal endocannabinoid control of hippocampus and amygdala input. We know hippocampus is for memory, again, not as simple. Amygdala is for the fear response. And in this research, it states that the endocannabinoid system gets active actually after the teenage. And that's where the responses are determined. Now, I'm just explaining it simply. We know this, the neutral stimulus, when paired with unconditioned stimulus, which is food, there is a salivation response. And when the neutral stimulus becomes conditioned stimulus, basically the bell, when it is associated with salivation, we call it conditioned stimulus. And this particular process is known as acquisition. Now, one simple thing. So there is this one experiment of a mouse. So when a mouse hears a beep, then the mouse gets a shock. When the mouse gets a shock, it freezes because that is its response for that fear, right? Now there are two molecules. This is 2-AG and anandamide. 2-AG and anandamide. So when there is increase in the 2-AG in the prefrontal cortex while we are giving the shock to the mouse, they have found that it doesn't freeze as much as the normal mouse. So it doesn't get afraid of that beep, which indicates that there is going to be a shock later. So with elevated 2-AG in the prefrontal cortex, it is less scared. But when you dissociate the beep from the shock, the extinction happens just accordingly. So point is, if the prefrontal cortex 2-AG level, which is one of the ligand for the cannabinoid receptors, when there is more 2-AG, the mouse doesn't, it gets less scared with the beep. The next experiment is when you increase the anandamide levels in the prefrontal cortex. When anandamide levels are increased in the prefrontal cortex, we find that the mouse hears a beep, gets a shock and freezes. And the freezing is not affected. With anandamide, the freezing is exactly the same. But what happens is that when the beep is not associated with the shock, we know that there is always dissociation can happen. So like in a dog's experiment, if the bell is not associated with the food, after about 20, 25 or many such stimuli, the salivation will not happen. Now, what happens that if there is more anandamide in the prefrontal cortex, this extinction doesn't happen on time. So the mouse is going to still be afraid of the beep, even when the beep is not followed by the shock. So in summary, what we are learning here is that what is the role of this endocannabinoid system is that when mouse learns to be scared of the sound, and when it is followed by the shock, if PFC's endocannabinoid system is not fully developed, the mouse may have a different and a stronger fear response. But if the endocannabinoid system is fully developed, the mouse doesn't, it responds more effectively. And as the endocannabinoid system in the humans develop after teenage and after adolescent period, probably this fear extinction and its development is also, affected because of the development and probably the effect on this endocannabinoid system in the brain, which is one of the researches that I had come across, and I've read about it. Now, with that, just few simple stuff. We know that CB1 and CB2 receptors, where CB1 has high affinity for 2-AG, which is arachidioglycerol. CB2 has high efficiency for arachidioglycerol as well. Low efficiency for anandamide. Same thing goes for CB2. CB1 is more in CNS. We have seen that CB2 is more in periphery. Next thing is, we know THC and CBD. We know that cannabis is a mixture of hundreds of alkaloids, two important alkaloids being THC and CBD. THC is psychoactive, acts on both CB1 and CB2, while CBD is an isomer of THC. It is inactive at CB1 and CB2. Its MAOA action is not known, but there are no psychoactive properties. One thing that they have understood is as more CBD increases, there is lower risk of hallucinations, delusions, and memory impairment. And if it is pure CBD, it has anxiolytic and antipsychotic properties, as well as anti-seizure properties, the indication for which it is promoted. When we now with this simple theoretical background, which I did not dwell too much into, I would like to proceed to the cases where I have used this preparation. So number one, this is the first case. This is the case of sleep-related hypermotor epilepsy. Now, it's a type of epilepsy where seizures happen mostly during sleep. These seizures are sudden, like this jerky myoclonic kind of movements. They are vigorous, and this type of epilepsy is usually diagnosed in childhood and adolescence. I have had 2 cases of sleep-related hypermotor epilepsy. I am presenting this one for you. This, if you can see the video. If you can see the video, you can see that there is this jerky movement which are happening during the sleep.
निकाल पहले इसके ऊपर है चिल्लाओ ना बैग में है मेरे.
As we have seen it, now this patient was with a pediatric neurologist, and she was on 3000 milligrams of valparin, 10 milligrams of clobazam, and 50 milligrams of topiramate. Already she was given Gardnerol and levetiracetam in the maximum possible dosages before. And when she was brought, she was having this drooling of saliva. She was unable to maintain the tone of her body. She was this drooped completely. And when the parents said that before the onset of all these seizures and everything, she was fine and also moving around and developing normally. When she arrived, when she came to me, what I did was, like, that generally the treatment of choice for sleep-related hypermotor epilepsy is oxcarbazepine or carbamazepine. So we gradually reduced and stopped and reduced valproate and topiramate, and went ahead with oxcarbazepine 600 milligram, lacosamide 100 milligrams, and I have started cannabidiol slowly increasing according to the body weight criteria. I went a little ahead of that criteria up to 200 milligrams. So it's a 5 to 10 milligrams per kg body weight. But this was a child. So in her case, I took it to 200 milligrams. And one thing I've asked Bhaskar sir was what to do for hypotonia. So he told me that you can use carnosine up to 3000 to 4000 milligrams for hypotonia. So that's what I've used. Now, after that, what happened is that she got slightly better. She started at least walking with a little bit. But after that, after a one month of recovery, she developed what is known as electrical status epilepticus in sleep, which we did one EEG to find there were continuous spikes and waves all over the record, and she was deteriorating again. Now, in this ESCS is a rare epilepsy condition, which I learned from after talking to another pediatric neurologist. So I spoke to her and I took her opinion, and she said it's a rare epilepsy condition where abnormal electrical activity in the brain occurs mostly during sleep and affects children. It causes severe learning and behavioral problems. So symptoms were seizure and cognitive decline. So we have increased cannabidiol to 300 milligrams. And with her opinion, she said that we have to start a course of steroids, which is in a tapering fashion, started with this 20 milligrams. Then over a period of 2 months, slowly, gradually reduced it. She said this is the only, approved treatment for electrical status epilepticus. And after that, she said Oxcarb is contraindicated in ESCS. So we've introduced breveracetam 100 milligrams now and increased cannabidiol to 300 milligrams. So now she's stable on breveracetam 100 milligrams, lacosamide 100 milligrams, and cannabidiol 300 milligrams. The cost is becoming the constraint for this patient now, but I've also consulted one more of my neurologist friend from US. So she said that in the long run, cannabidiol is a good option for this patient because of a sleep-related hypermotor epilepsy. They are likely to go into this ESES, which can cause cognitive decline over a period of time. So because of that, she said cannabidiol is probably indicated in these patients of epilepsy. So now she's maintained on this particular thing, and since last 3-4 months, she hasn't had any episodes of those those epilepsy attacks in her sleep. This was the first case, which was epilepsy case. Again, sometimes we may encounter these cases in our practice. There was one more of sleep-related hypermotor epilepsy. She also is doing better on it. Now, slightly moving towards the psychiatry, of course. Now, we all must have read about Jesuin syndrome in our in our psychiatry practice. Most of our teachers actually teach us about it. Now we know that this is an older term. This kind of term doesn't exist now. But a characteristic personality syndrome consisting of circumstantiality, altered sexuality, intensified mental life is present in some or most of the epilepsy patients, which is very difficult to treat. We tried from our end by using depending on symptoms, if what are the symptoms of that epilepsy, depending on where the subthreshold seizures are happening, we sometimes use antidepressant or antipsychotic for the mood disturbances or a mood stabilizer as well. But proposed mechanism is inappropriate hyperarousal due to subthreshold seizures. Now, I have seen 3 such patients, who are on epilepsy treatment stable, but have this kind of characteristic features wherein they get angry very easily. In that anger outburst sometimes may act out in that sense. I've given them this cannabidiol along with lamborexant because of the mechanism, which is inappropriate hyperarousal. So as much as they can tolerate in that sense, but it is too soon to comment whether it will work in these cases. So yet I'm I think I would want to give it some more time before commenting on whether it can be used here. But this seems like an area that it affects cognition. The subthreshold seizures which are happening, which are not causing actual seizure, can actually affect and alter the cognition and the perception of the information. So it could be used over there. After this, the next slide is this is again a 7-year-old male with autism spectrum disorder and seizure disorder and repetitive behaviors of ASD along with ADHD again. So he was in the special school, but he was still not sitting at one place. He was actually pushing other kids. एक दो बार ऐसा हुआ है कि कहीं तो ट्रिप पे वो गए and he has pushed the kid, and thankfully the kid did not sustain any injuries, and these kind of episodes were just happening suddenly. Plus he was that all solitary play of ASD was there. He was on 2000 milligrams of valproate, 20 milligrams of clobazam, and risperidone was 4 milligram and triaxiphenyl 2 milligrams. At this point he was brought to me. Then one thing that what I did was, when I started him on methylphenidate, he was ready to be calm and sitting at one place, but he exhibited this, I don't know, some typical phonophobia. So I don't know if anyone of you have experienced or seen this. So he used to be scared of loud noises. He was sitting still in a corner. He had loss of appetite. Of course, there were no repetitive behaviors, but this wasn't desirable. because the family members were like, this way it is not going to work. So in order to counter that, I have given him, various things. So maybe for the ASD, repetitive behaviors, naltrexone, also gave him endoxifen, also to reduce that anxiety, propranolol and clonidine as well. This was a 12-year-old kid, but he still was exhibiting the same symptom on methylphenidate. फॅमिली मेंबर्स वन डे कॉल्ड मी की फटाक्यांचे आवाज आले की लगेच धावतो, जोराजोरात ओरडायला लागतो, पलंगाच्या खाली लपून जातो. अगोदर असा नव्हता करत. Then in that desperation, even not moving on to anything else right now, I have given everything. So I've tried going back to risperidone, also tried olanzapine as well, but this thing was still not getting better. Eventually, then when I added cannabidiol, now whether it was the prolonged duration of having given those other medicines which have subsided this behavior, or whether it was addition of cannabidiol that has subsided this behavior, is again something that can be contested. So we can't make that association right now for sure. But right now, this particular patient who was very difficult to manage, even for the special schools, wasn't attending to the occupational therapy or the speech therapy as well. Now is on methylphenidate 36 milligram, naltrexone 50 milligrams, clonidine 100 micrograms, risperidone 1 milligram is back again, propranolol 40 milligrams, clobazam 20 milligrams, which is for his seizure. Valparin I've reduced to 200 milligrams because he was having hyperammonemia as well. And cannabidiol was taken to 300 milligrams. With gradual increase in cannabidiol, he's getting better in OT and learning new words. Is the recent feedback from the parents. This has been his third follow-up since I have given him cannabidiol. So this is again one more interesting area, because all of these areas, as you can see, are interestingly related to cognition. And there is a research that when this cannabidiol was given to, you can check that out. I may be able to share the link later. They've given it to in a cohort study for about 315 patients, and about 240 of them were children. They have found significant improvement apart from seizure control in the behavioral, features like, aggressiveness, stubbornness, and all those things as well. Also with sleep as well after cannabidiol. So this was the case. The fourth case is now this was treatment-resistant OCD, or to call it schizo-obsessive, I don't know. I have, because the list is too long, so that's why I haven't mentioned it over here. So entire pharmacopoeia, definitely I have, we have this thing at Sion Hospital, that if it's a treatment-resistant OCD, you have to use fluoxetine in the maximum dose, sometimes use clomipramine in the maximum dose, and give a cover of anti-epileptic so that seizures don't happen. So you name it, we have done it. For this patient, she has also taken opinion of 3 more senior psychiatrists as well in Mumbai, because I've encouraged them to go and actually talk to someone else as well who can offer something else. Few suggestions we have taken. Ultimately, she is also following up with me. So we have gone up to 160 milligrams of fluoxetine, about 150 milligrams of clomipramine. I have also given at different place, not together, fluoxamine up to 400, 500 milligrams, sertraline up to 400 milligrams. We have given memantine up to 60 milligrams in total, and name it, I have given everything, but she just wasn't responding to anything and wasn't getting better. It was a more of a thought OCD, like there is this obsessive thoughts, and with less compulsions, but there were these micropsychotic episodes in between. Right now, she is maintained. This is the one that is on the maximum dose of the cannabidiol that I have used. So right now she's maintained, although fluoxetine in the past have been taken up to 160 milligrams. I have brought it down because even after bringing it down, she seems to be doing better. So up to 60 milligrams now she's on fluoxetine, 75 milligrams of clomipramine, memantine 60 milligrams, propranolol 120 milligrams, paliperidone 6 milligrams, and cannabidiol 600 milligrams is the dose at which currently she's doing better. Now she's 17 years old, and she weighs up to 110 kilograms. So the dose of cannabidiol is also 600 milligrams for her. But I've still used a little higher dose for her, and she is showing improvement after a long time. She's engaging in the activities that is given to her, and she is also showing willingness to work on herself and also going to school now. So that's another case where I've used this. Now, there is this one more case, which is schizophrenia with a family history of OCD. Now, in this particular case, this patient is on risperidone 4 milligram, clozapine 25 milligram, clomipramine 50 milligram. He was still exhibiting the episodic aggressions, as the father described, that he was just sitting still, thinking about something, and अचानक से उसको गुस्सा आ जाएगा, वो सिर्फ सब कुछ उठा के मारने लगेगा, किस सबको आजू बाजू में जो भी रहेंगे सबको मारने लगेगा. First, we even thought maybe why not give him valproate as well. So have tried valproate as well up to 1 gram, but that still did not reduce his episodic aggression. The episodic aggression was getting very out of hand, and it was causing problems in their household. He was just getting aggressive without any notice. Otherwise, a very good chap, doing praying 5 times a day, also insisting that his family members pay attention to the religious rituals and scolding them if they don't. These were some obsessive features in him. His mother has a frank obsessive compulsive disorder, to the point that अगर दवाई कोई खरीद के लाया बाहर से, तो अगर वो कहीं पे नीचे रखी भी रहेगी, तो she won't touch it, she'll just throw it away. Now they are planning to get her to see me, but she's still not ready yet. But there is that family history of OCD in this particular kid. When I was increasing clozapine beyond 25 milligrams, he wasn't really tolerating it well. So what I did after that, and even for this patient as well, I have tried giving him the usual things for the impulsivity, which is naltrexone up to 100, 150 milligrams as well. But even after that, these things were not getting controlled. At which point I have decided to start him on the cannabidiol. Right now he's on 200 milligrams of cannabidiol per day. And in zuclopentixol, I was giving him once every 15 days before, which got the attacks in control, episodic aggression, but it was still present. So now after cannabidiol, in last 3 months, he hasn't shown that that episodic outburst. So I have spaced out the zuclopentixol injection to now just once in 2 months, and he's continuing on 2 ml of 200 milligrams of cannabidiol every day, along with all other his medicines, along with naltrexone 150 to 150 milligrams as well. So he's doing better on this combination right now. There are many more cases. Of course, this was one schizophrenia that I've told you. There was one more patient with schizophrenia. Again, we can call it something on the line of schizo-obsessive disorder itself. So this was the patient who had this. He has extreme anger and hatred for his sister, and he just blames her for everything that has happened with him. He has had frank psychotic episodes, not working since last 20-25 years now, and he at any moment he just says that you have ruined my life. The typical blaming symptoms that you see in the patients of chronic schizophrenia. He has even written a book, which if he has gifted me, and if you read through that book, you can actually see so many of the thought disorders actually playing out as well. He has written and published that book as well. So this particular patient was another patient, not this one. And he was of course given all the antipsychotics possible, even with the combination of clomipramine, to think that probably if it's a rumination kind of a thing which is actually causing the psychotic episodes, then maybe that will get in control. But still he wasn't better. So eventually, now this was again one more who was on a higher dosages of cannabidiol, which is 500 milligrams a day. And father reports that his those behavioral aggressions, and that he was after a long time, he started speaking to his sister as well. Again, not something to be taken with a pinch of salt, but this is one of the many cases. I have just presented a few cases of all the things that I have seen in that sense. There's a 6th patient. This was late onset seizure disorder with behavioral disturbance. Now, this chap was in 9th standard when he had his first seizure episode, confirmed on EEG. And but MRI was done. It was, of course, MRI wasn't significant for any changes for that matter, which can tell us that it is seizure disorder, but he was having these episodes. After starting this treatment for the seizure disorder, which was levetiracetam, he started getting very aggressive to the point of also the mother reported that in last 3-4 months of him having these medicines, he used to wake up at 2 a.m. or 3 a.m. and used to awaken the mother ki चल उठ जेवण बनव माझ्यासाठी झोपलीस काय and used to be very rude, which was very unlike him. And this was just increasing day by day. He was staying awake late in the night, was used to play some game as well, something like PUBG, and used to sleep at 5 o'clock, stopped studying and everything. So all these things started happening. At which point I've suggested them to also, which is what we do, that if there are behavioral symptoms with levetiracetam, we try to shift them to breviracetam. So we did that. with it, his behavioral symptoms got much more in control, but he was still exhibiting these symptoms. The aggression was still there occasionally, for which I've given him olanzapine and fluoxetine combination. With that, he remained stable for a long time, about an year and a half. He was much better with that combination itself. And in between, he had 2 episodes which the parents were not sure if they were semiologically similar to seizure disorder or not, but he fell unconscious. So to leave no stone unturned, I thought rather than giving him something else, let's also give him an adjunct anti-seizure, which could also work on his behavioral disturbances. And that's why I've started him on cannabidiol. Right now, he's maintained since last about 2 months. I think he's maintained on this breviracetam, olanzapine plus fluoxetine combination, and 200 milligrams of cannabidiol. He'll be probably appearing for his 12th standard exam this year. So this was one late onset seizure with behavioral disturbances. 7th patient, I think, is the last but one patient, and then I'll be finishing it, leaving the floor open for discussion. This was another patient with polysubstance use disorder, seizure disorder, and cognitive damage, which was seen on her testing. I've just shown her reports over here. The Bender Gestalt test and the MMSE2 examination, which showed that there is a cognitive disorder, and which the patient brought herself. And but just looking at her, I could see that she also wasn't taking her seizure medicine since a long time, and she had a very bad episode of seizure recently. After that, she came here, and the substance use was ongoing. She was using all the known substances to mankind, for that matter. And she came to me in this condition. The cognitive damage was very apparent in her dealings and in her talking as well. She said she had inability to remember anything. She used to have blackout episodes as well. So current regimen, she is doing better on naltrexone 50 milligrams, vernicillin 2 milligrams, oxcarbazepine 600 milligrams, olanzapine plus fluoxetine combination, and cannabidiol 300 milligrams. And she just just today itself, I have spoken with her. So she is doing well on these medicines, currently taking it regularly. Only thing that she complains about is the cost of cannabidiol, which I told her that, it's just, I don't know when that would come down. But mostly I've seen this cognitive improvement after starting cannabidiol. And since we know that generally as we are talking about NMDA receptor modulation in psychiatry, probably, this cognitive disorder is a major thing which is affecting us in most of the psychiatric disorders as well, right? The next case is the last one, is the intractable pain disorder. Now, out of the cases that I've just presented, 2 cases were also in my lamborexant PPT, where I've used lamborexant as one of the molecules. Same thing with the intractable pain disorder, Ehlers-Danlos syndrome. She had Ehlers-Danlos syndrome with tethered cord syndrome and ADHD, diagnosed as ADHD as well. So you can see the list of medicines and some self-medication that she was taking. So along with, she was also taking cannabis, also taking psilocybin as well, and most these medicines. And she has made this chart that on the second column there are effect, and on the third column there are side effects of all the things that she was taking for that. So in this case also, first I've suggested CBD. But I think because of the cost factor, she went ahead with a CBD preparation which was available, uh, over the counter or somewhere, some from Ayurvedic preparation that she has taken. I told her that we can't be sure of the constituents of the Ayurvedic CBD preparation. So I've suggested her to shift to the CBD preparation which is available and which she has started taking since last month now. And I'm waiting to see if that is going to have any effect. One more important thing, that for this patient, I have also given ketamine injections for her pain, because of which she could at least walk, because of otherwise she had to use the crutches without disability. The pain was so much that she had to use crutches to even walk. After ketamine injections, she started using her cycle and walking and going to college as well. But the pain was still there. And for that residual pain, I've suggested that let's shift to something, try to shift to something oral. Of course, the cost difference between ketamine and CBD is huge. But I believe that if this has some effect on her, because otherwise regular ketamine injections was causing its own problem. She also had to get the cannula inserted because the veins were not seen after about 8 or 10 sessions of ketamine. So I'm hopeful that this will have the desired effect on her because of the mechanism of action of CBD as well. Of course, there are many more who didn't respond. All similar cases on the similar lines, the Jashwin syndrome or the patient with the cognitive problem. Some actually just opted out because of the cost. But there is a highlight. I'm highlighting the need for accurate etiological diagnosis in psychiatry, because a label for the behavior isn't a diagnosis. It is like a fever which has a million causes. So we have to think of it like a behavioral phenotype of unknown origin and dig deeper into where exactly the problems could be coming from, and maybe try to treat it accordingly. And that's the opportunity that this even CBD, the new preparation which is available for us, it has to offer as well, because we can see that this endocannabinoid signaling system in the first mouse experiment, that it affects the fear conditioning, that whether you will remain afraid for a long time or not is also affected by this system. So its development during the teenage years, and generally people succumbing to this peer pressures and using cannabis and everything in the teenage years as well, could be correlated to the starting or the heralding of many psychiatric diseases, as in, could be heralding the expression of the hidden genes of the psychiatric illnesses. Because I have seen one more case who, after using cannabis disorder, he started having this paranoia that if he's sitting in the train, the people around him are not sitting with him, because probably they think that he is gay. Is this obsessive thought which was like affecting him when he started coming to me. Now he's doing better. Of course, I haven't given him CBD preparation in that case. I have just I just thought I will be stuck with clomipramine and using a low dose olanzapine along with it, and he's doing better since then, and also naltrexone for that. So in some cases where these initial available remedies are useful, I haven't gone on to the CBD, of course, because of the cost associated with it. And I think that's the end of my presentation. And this is just the beginning, because, and take it with a pinch of salt. Please share your experiences if you have used it in some patients, so that we can explore it more together. Thank you so much.
Thank you, Prashant. It was a very excellent presentation with practical inputs and your experiences with the cases. May I request Dr. Akhil to come in for his sharing his views about this molecule and his experience?
Hello.
Yes, sir, Doctor.
Am I audible? Just give me a minute.
Yes, yes.
First of all, thank you, doctor. It was a wonderful presentation.
Thank you, sir. Thank you.
Very well presented.
Thank you.
So there has been a lot of curiosity about this molecule. And frankly speaking, I have not yet used this molecule. So my practical experience is zero. And it was great to hear so many cases from your end.
Thank you, sir.
But whatever I have read and I have gone through various articles, so autism is the second most most common indication where cannabidiol has been used.
Yes,
The
sir.
first one obviously being the epilepsy syndromes, where it has been approved. But amongst the off-label indications, autism is the second most common indication. And various studies, people have seen some wonderful results. Although at times it is a bit difficult to pinpoint what areas to target
Right,
and
sir.
what symptoms to target, because the articles generally cover a complete range of symptoms, from hyperactivity to self-harming behavior to even cognitive symptoms also. But the results have been quite decent, and this is especially one area where I am trying to focus, and I think I'll be using this.
Right, sir. Right. I think but you're very right. There are so many researchers on especially the repetitive behaviors of autism is we know that neurobiologically similar to probably the subthreshold seizures that are happening in the sense, and maybe hypothetically speaking, that could be the area where it can be used, because we find ourselves at a loss when the patients like that come to us, because you use anything, it just backfires. Also, the methylphenidate I've seen in autism spectrum disorders, it always gives this kind of symptoms, that they are just quiet and sitting in the corner and not engaging. I don't know if you've seen that, sir. Have you seen that happening as well?
Yes, it is quite common actually, I suppose. Because after a period of time, especially if we are talking about ASD, the patient either stops responding or the response is very erratic.
Right,
On
right.
some days, the patient will behave as if he is absolutely fine. On another day, he
Right, right.
will behave as if he is treatment resistant. So I assume that is part of the disease process itself, that as the disease progresses, the symptoms are going to get worse. But yes, there is definitely this new ray of hope.
Thank you, sir. Thank you.
Another thing that I'm actually interested is cannabis use disorder. Can you
Yes.
reflect a bit more on that? Because we
I-
do not have anything to give to the patient who are using this cannabis. Right.
Again, theoretically speaking, of course,
Yeah.
the alcohol, it's a combination of hundreds of alkaloids, like you said.
Yes,
The
yes.
most common being THC and CBD. So far, we know that THC is responsible for the addictive properties, and this CBD preparation is a purer CBD preparation, which literally knows THC, maybe some amount probably. So there are this
0.1 maybe.
other internationally approved molecules for where there is 1:1 THC and CBD, some other proportion of THC and CBD. But in cannabis use disorder, I am also interested, and I could not really find the theoretical basis, but probably maybe someone with already existing say developmental condition who is into cannabis use disorder, if we can work on this endocannabinoid signaling, maybe in those patients, this CBD can be used as a treatment for cannabis use disorder. But otherwise, theoretically, I am also curious to know if we can really use it in cannabis use disorder. I have given it to 2 patients of cannabis use disorder, but again,
okay,
it's in the sense, but only because there were pre-existing neurodevelopmental conditions in them, which probably might have set off this route to use cannabis in a dependent manner. And only in those patients I've used it, sir.
I found a couple of articles on this, the use of CBD in cannabis dependent patients, although they are not really very convincing. One of them was about intranasal spray, but obviously we do not have those things
We don't have.
available here.
Yes, yes.
And then there are products, as you said, with some component of THC that is available.
Uh-huh.
So, but we only have CBD with us right now. So
Right.
let's see. So
Uh,
over to you. Thank you.
Yes, thank you, Dr. Akhil.
Dhananjay sir.
Prashant, there are a couple of questions we are having from
Yes.
the audience,
Mhm.
and glad to share that there is 150 plus audience we are having, approximately 160 just to the 200 also. So people are really interested in this topic.
Yes.
First question is related, as already we have discussed this, the role of cannabinoid in addiction disorders, more of cannabis disorder.
Hmm.
Second, they are asking about the role of this molecule in treatment-resistant insomnia and treatment-resistant anxiety.
Yes, yes. I think treatment for that matter, the study that I mentioned, it's there, the cohort study of about 300, I think 311 or 312 patients, in which it has shown that if given to the patients with seizure disorder, it actually has improvement in their sleep quality. And we know that the improvement in sleep quality is also, it also translates into improvement for the seizure problem as well. So that way, indirectly, it does have a role on in the sleep disorder. Secondly, another molecule which is available also parampanel, because of its action on the AMPA receptor. That is also good for in the seizure disorder I'm talking. But if we are talking about treatment resistant insomnia, if nothing else is working, and there are some patients who are benzodiazepine dependent. So I have one such patient in which the benzodiazepine dependence was very bad. She was actually taking 2 milligrams of Restil up to 4 or 5 tablets a day, Lonotril 2 milligrams literally 5 to 6 times a day, and she was working and functioning with that. Without that, and even a lesser dose, and she was having trouble concentrating on anything that she was doing. Which slowly, what I did was we used a trick basically. So I thought a lesser dose of alprazolam would do her good, and she was otherwise not ready to take any antidepressant or antipsychotic. So because she was googling it, so I gave her this combination of fluoxetine and alprazolam, and I told her you use that up to 3 or 4 p.m. Up to 3 or 4 in the afternoon, as many times as you required, up to 5 to 6 tablets a day, and don't use Restil. And I told her after 4 o'clock, I gave her lemborexant, the Davigo, and I told her use 5 milligrams of tablet as and when required from 4 o'clock until the end of your day. So with that, she stopped using clonodril. Now she's taking 2 milligrams of Restil, 3 tablets a day, and this 4 tablets of fluoxetine alprazolam, which is 0.25 milligrams of alprazolam. So total dose of 1 milligram. And uh, at night, she's using only the lemborexant. So in that, to reduce her the use of alprazolam now and dependence for the sleep as well, what I did was now I have asked her to start cannabidiol and slowly increasing the dose. So I don't know whether it will work there, but that treatment resistant insomnia is one thing which is also interesting where it can work. As far as treatment resistant anxiety is concerned, I think it has the role of, on the basis of the mouse experiment that we have seen, how the initiation of that anxiety response can be hampered, and you may be scared less often for those responses, is we have seen when there is 2 Ag levels are increased in the prefrontal cortex. So theoretically, there is definitely basis for it. But for in terms of our selection of patients, we have to be really careful. And like I mentioned in the one of the last slides, we have to understand the underlying. So it's like, it's not, depression is like fever or anxiety is like fever. So it's like there is pyrexia of unknown origin, there is anxiety of unknown origin. If that anxiety is obsessive of OCD, if that anxiety is of panic disorder, maybe that will determine where it can be used. But too early to comment, sir.
Thank you very much, Prashant. There is I got a message from the backstage that we are having 220 plus delegates by now watching us. Important thing, last question, I will take this question, and this is very practical and realistic question from one of the psychiatrists. He says, what about the cost burden?
Yes, that we have to ask to in-touch people as well. If
True.
they have to work on the cost of it, because cost is becoming a factor. Even the patient that I said, the first patient, sleep-related hypermotor epilepsy, they are also poor patients. Actually, the story is that they are here in Bombay only for treatment of their daughter. Since last 1.5 years, they are here from their village and working here, living in a temporary house, but they have their house in the village only to get her better. And the cost is a very major factor for most of our patients, as we know. It's the reality of our practice as well.
Yes. Thank you, Prashant. Thank you very much, Dr. Prashant Chaudhary, for excellent lecture and your sharing your practical experience. I will also like to thank you, Dr. Akhil, about giving his insight about this molecule. And I express thank you to team Intasting and especially Michael sir for giving me this opportunity to moderate the session. Over to you, sir.
Good evening, doctors. I, on the onset, would like to thank you, Dr. Prashant, for a very excellent presentation, very bold, I would say, bold and excellent presentation on the various off-label psychiatric conditions, like you have touched on autistic spectrum disorders, ADHD, OCD, schizophrenia, substance use disorder, as well as intractable pain, and sharing the common light that it has a good potential in improvement in the behavioral as well as sleep conditions. Thank you for the very interesting cases that have enriched all the 220 plus online viewers with your practical and experiences. I also wish to thank you, Dr. Atul Chopra. Sorry, we had not introduced you earlier. Consultant psychiatrist of Mind Heal Clinic. Thank you for sharing the knowledge that you have learned and read, which is definitely beneficial and has proven to be beneficial as well to this today's webinar. Last but not least, thank you, Dr. Dhananjay, for chairing this session and moderating it very well. And last but not least, a big thank you to the 220 odd psychiatrists and neurologists and clinical physicians who have attended today's webinar and has been an enriching and enlightening experience for all of us. Thank you, all of you. Thank you very much. Good night.
Thank you. Thank you. Good night.
Thank you and good night, everyone.
Thank you very much.
Great to
Thank
see
you.
you.
Good night. Good night. Thank you.
Good night, sir.
Thank you, Dr. Dhananjay. Thank you.
Thank you, sir.
Good
Thank you,
night,
sir.
sir. Bye, sir.
Thank you, Vijay.
Good night, sir. Good night.
Thank you.
Good night.
Thank you, Dr. Prashant, as well. Thank you.
Thank you, sir.
Thank you.